Good morning, ladies and gentlemen. The topic of today's lecture is Kaposi's sarcoma. Introduction. Kaposi sarcoma is a multifocal endothelial proliferation with low-grade malignant potential caused by human herpes virus 8, HHV8. It manifests most often with cutaneous lesions with or without visceral extension. Its precise histogenesis has also been somewhat controversial, although the recent evidence points towards the lymphatic origin. So there are few things which are important in this introduction. Number one, it's an endothelial proliferation with a low-grade malignant potential. So it's a tumor of blood vessels with a low-grade malignant potential. It is caused by human herpes virus 8. So although this is a low-grade malignant potential carrying vascular lesion, but the cause is an infection, and that is a human herpes virus 8. It has both cutaneous and visceral involvement, and it is thought to originate mainly from the lymphatic vessels. There are 4 distinct types of Kaposi's sarcoma. The first is the classical type, usually seen in elderly on the distal extremities, mainly from the Mediterranean region and the Jewish population. There is no internal or mucosal lesions. The second is the AIDS-related Kaposi sarcoma. The affected individuals are mainly young, adult male. The disease disseminates widely and proves fatal, with skin and mucosa is extensively involved. Then the third is the immunosuppression-associated illness. It has an indolent course. It sometimes regresses after stopping the immunosuppressives. And the last is the endemic or the African type. It is again subdivided into 2 types, the one which develops in a middle age and the other which develops in young children, and it is usually fatal in young children. Incidence and prevalence. The worldwide incidence of Kaposi sarcoma varies dramatically from less than 1 per 100,000 in most areas of Western Europe and Northern America to over 22 per 100,000 in Central Africa, where the disease is mostly endemic, as well as the HIV infection is rampant. So in Africa, the incidence of Kaposi sarcoma is 22 times as compared to the incidence in the developed world. It is the most common neoplasm among the HIV patient, the untreated HIV patient. So if anybody asks you which is the most common tumor in HIV patients, so it is Kaposi sarcoma. There is a strong predisposition among the immunocompromised individuals that reflects a dependency upon the host immune system. So if the immunity is unable to control the human herpes virus 8, it is likely to cause a disseminated Kaposi sarcoma. There is a male predominance in all the 4 subtypes of Kaposi sarcoma. Predisposing factor. Although HHV8 is the causative agent, it is insufficient to cause Kaposi sarcoma alone. So it requires multiple cofactors. The most popular of or the most powerful of the cofactor is HIV co-infection. which elevates the risk to develop Kaposi's sarcoma 20,000 folds. There is also a genetic basis to predisposition of Kaposi sarcoma, mainly in classical and endemic subtypes. Although there is one report of autosomal recessive OX40 deficiency that causes the classical Kaposi sarcoma in a child born to a consanguineous parents. This loss of OX40 function results in decreased effector CD4 T cell function, so indirectly leading to selective immunosuppression against the HHV8 virus. Several environmental factors also contribute to the development of the disease. One is the quinine use, which is used in anti-malarial and to process the heroin. Then nitrile inhalants, which is again a common drug abuse, which was prevalent with the start of AIDS epidemic. Then ACE converter enzyme inhibitors and volcanic soil silicates. These are the areas where the Kaposi sarcoma is endemic. So now coming to the histopathology. According to histopathology, Kaposi sarcoma has a patch stage, a plaque stage, and a nodular stage. So the patch stage is the early stage where you can see the increase in vascularity in the upper dermis, along with fibrosis and light chronic inflammatory infiltrate. So number of vessels is increased, inflammatory infiltrate is there, and there is fibrosis of the dermal collagen. Then the vessels are swollen with hyperchromatic endothelial cells. So there you can see that the endothelial cells in the blood vessels are swollen. Now talking about the infiltrate, it mainly consists of admixture of lymphocytes and the plasma cells. So plasma cells is usually seen in secondary syphilis, but in Kaposi sarcoma, there is also a predominance of plasma cells. In patch stage, there is extensive dissection of collagen, whereby the new blood vessels and the hemosiderin deposition, which occurs because of the RBC extravasation. Then comes the plaque stage of Kaposi's sarcoma. Now the changes, that is the fibrosis and vascular proliferation, involves the whole thickness of the dermis. You can see this vascular proliferation deep in the dermis. And here, there is an extensive vascular proliferation. So these all spaces are lined by endothelial cells, and it is seen throughout the dermis. Then a very popular sign which is seen in patients of Kaposi sarcoma is the promontory sign. It is described as the formation of vessels surrounding the vessels. So this is a vessel, and this vessel is surrounding the vessel. So new vessels keep on developing and sheathing or surrounding the original vessels. In addition, there is increased number of spindle cells are present, and these cells are mainly the endothelial proliferation. Dissection of collagen, you can see the collagen divided into small facets. These are the facets. And the spindle cells, you can see in this picture, there are so many spindle cells, have a pale cytoplasm and oval or elongated nuclei. And occasionally mitosis is also seen. Now this is the nodular stage. A well-circumscribed dermal nodule is seen. Spindle cells have eosinophilic cytoplasm. These are pink cells. These are the spindle cells. Scattered between them are numerous slit-like vessels with RBCs. And now this give a sieve-like appearance. Several mitoses are also seen. if you see these spindle cells, you can also notice these hyaline inclusions within the spindle cells. The spindle cells express CD34, CD31, and podoplanin D240. Human herpes virus 8 is regularly present within these cells. The causative organisms. All forms of Kaposi sarcoma are associated with human herpes virus 8 infection as the etiological agent. The gamma herpes virus is easily transmitted through saliva and blood products. Seroprevalence correlates highly with Kaposi sarcoma incidence. So in patients of Kaposi sarcoma, the serological tests for human herpes virus are strongly positive. These tests are based on antibodies. The characteristic spindle cells of Kaposi sarcoma are latently infected with HHV8, and expression of the latent associated nuclear antigens, V-cyclin, viral flip, and viral microRNA suppress the apoptosis and drive proliferation. So these viral associated nuclear antigens prevent the apoptosis of the viral infected cells and causes proliferation of these viral infected cells. Clinical features. The patch stage of Kaposi sarcoma manifests clinically as irregular pigmented macule. Patient in this context may be immunosuppressed and have subtle lesions that resemble a bruise-like trauma. These, you can see the bruise-like lesions on the nose as well as on the foot, most likely. Most often seen on the feet and occasionally on the hand, ear, and nose. The lesions are typically dark blue or purple and partially blanch when they are tumored, but generally they don't blanch. So lesions on the feet. They are most often multifocal, present on multiple areas, fusing to eventually form plaques and tumor to a size of several centimeters. Edema of associated limb can follow, although it is sometimes the presenting finding, particularly in the endemic forms in adults. In AIDS-associated Kaposi sarcoma, these lesions occur in large number. So dark pigmented plaques are widely distributed here on the back. The lesions are also seen in the oral mucosa. Locally aggressive lesions can become ulcerate, fungate, or leave pigmented scars. So the ulcerated lesions are quite common. Lymph nodes, mucosa, and viscera are involved, and the disease progresses. In the endemic form, children develop classically the lymphadenopathic type. The clinical variants. The classical Kaposi sarcoma, which develop in adults, start in the lower extremity and progress very slowly. Iatrogenic or immunosuppression-related Kaposi sarcoma resembles a classical type with varied site of presentation and again a subtle lesions. In the endemic or African type, the tumor is locally aggressive in skin, but rarely so systemically. African endemic form in children is typically lymphadenopathic type. Lymph nodes are involved with or without caseation and is often fatal within 2 years. The AIDS-associated Kaposi sarcoma is rapidly progressive, involving head, neck, trunk, and mucous membranes. Fulminant disease with widespread nodal and visceral involvement occur and is expected particularly if patients are untreated with heart therapy. The differential diagnoses include hemangiomas, melanocytic proliferations, angiodermatitis due to stasis, and bacillary angiomatosis, which may coexist with Kaposi sarcoma in AIDS patients. The staging of Kaposi sarcoma in context of AIDS clinical trial group. There are two subtypes, the good risk or 0 or poor risk 1. The good risk contain following: the tumor T confined to skin and or lymph nodes with minimal oral disease. And the immune status is good with CD4 count greater than 200 per microliter. There is no systemic illness or thrush or B symptoms, and performance status is greater than or equal to 70. Then the poor risk group is associated with tumor, which is associated with edema or ulceration. There is extensive oral involvement, extensive gastrointestinal involvement, and it is seen in non-nodal viscera. The CD4 count is less than 200. It is associated with B symptoms. The B symptoms are the unexplained fever, night sweats, more than 10% weight loss, or diarrhea for more than 12 weeks. Performance status is less than 70 and is associated with other HIV diseases or illnesses like neurological diseases and lymphomas. The stratifying treatment of patient with T0 versus T1 status is combination of antiretroviral versus combination of antiretroviral and liposomal anthracycline therapy, respectively. So for T0, only antiretroviral therapy is sufficient, but with T1 status, you have to combine it with liposomal anthracycline therapy. Complications and comorbidities. Kaposi sarcoma is associated with both Hodgkin and non-Hodgkin lymphoma, and HHV8 is the proposed etiological agent in multicentric Castleman disease and primary effusion lymphoma. The disease course and prognosis. The disease outcome depends heavily on the tumor extent and the systemic involvement. The ACTG group T1 has 3-year survival of 53%, over 80% for other groups. So gastrointestinal tract, particularly small intestine, is the most common site of visceral involvement, with massive hemorrhage as the serious potential complication. Then after the GI tract, lungs, heart, and liver are most commonly involved organs. The visceral involvement is most commonly seen in AIDS-associated Kaposi sarcoma, with lungs, GIT, and lymph nodes the most common sites. Investigation. Laboratory studies are typically normal in Kaposi sarcoma, and direct testing for HHV8 is not routinely used. Testing for HIV status is important given the efficacy of heart. Management. So the management depends on the clinical subtype, although no approach is definitely curative. Kaposi sarcoma is highly radiosensitive, and complete response is seen in up to 93% of patients on radiotherapy. The localized cutaneous disease, excision, and cryotherapy is used. Intralesional vinblastine, interferon alpha 2b, and imiquimod are effective, although recurrence is common. For AIDS-associated Kaposi sarcoma, institution of heart to treat HIV often result in regression of Kaposi sarcoma, but up to 50% never achieve total remission. Similarly, diminution or cessation of immunosuppression in iatrogenic Kaposi sarcoma leads to regression of the lesion. In this setting, sirolimus has been reported mostly to induce regression in Kaposi sarcoma. The disseminated Kaposi sarcoma is important as it is responsive to medical therapy, although there is no definitive regimen. Response of over 70% is reported with liposomal doxorubicin, vinca alkaloids, etoposide, and taxanes. Liposomal doxorubicin and paclitaxel are approved by FDA as first-line and second-line treatment for advanced Kaposi sarcoma. There are also anecdotal reports of response to imatinib and sorafenib. So this ends the talk today. It was a brief lecture, but it was important as Kaposi sarcoma is not an infrequent occurrence in our setup as well. So thank you very much, ladies and gentlemen, for patient listening, and see you next time with another edition of my lecture. Goodbye and have a good day.